Okay. So let me introduce right now Juan Diego Villegas to you. Juan Diego is the past president of IPPS, was the past president of IPPS. IPPS stands for International Pelvic Pain Society, and he is now chair at FIGO, Minimally Access Surgery Committee, and scientific director of ALGIA, Advanced Laparoscopy and Pelvic Pain Center, Pereira, Colombia. And he's my brother as well. But the thing is, JD, I tried to introduce you, but you give a very short CV to me. Would you like to add something to this? I'm sure there are many to add this. Your fellowship in United States, as far as I know, about pelvic pain.
The most important one is that I'm your brother, Erkut.
Thank you very much. Okay.
Yes, I completed a fellowship in chronic pelvic pain in Birmingham, Alabama, like 15 years ago with my mentor, Professor Paul Perry, who already passed away. But yeah, I completed a fellowship with them, and also a fellowship in minimally invasive gynecological surgery. And I've been related to several international societies, including the board of directors for the AGL and some others.
So I know there are many things, I mean, to tell about you, but and today he's gonna speak about laparoscopy. It is hysterectomy, total laparoscopic hysterectomy. So JD, it's time to start now.
Okay, sir. Let me get my pen, and I'll be right back.
Okay. So most of us now do hysterectomy by laparoscopy. We are using laparoscopy recently. So therefore, I would like to learn about, or I ask request Katie to talk about laparoscopy, laparoscopically how we do surgery. This surgery, I mean hysterectomy by laparoscopy. So it's very important, I mean, to learn about different techniques. So JD, okay.
Okay, do you see my screen now?
Yeah, we see.
Okay, because I cannot see myself in this platform, so you have to drive me through to be sure everybody can see me and can see my presentation. Is that correct?
Yes. We see you and also the slides on the screen.
Okay, and let's see if you can see them. Yeah. If you can see them move. Okay. So shall we begin?
Sure.
Okay. So first of all, I want to thank you, Professor Attar, for your kindness and for your invitation. As I said, for me, it's a big honor and a privilege to be here with you today. And I want to thank you all of you that are already at the room, and the other ones that are connected to the web. Thank you for inviting me and for having me, for joining us today. And I hope the things we're going to be talking about are not only interesting, but also useful for your day-to-day practice and for your patients. And I have to start saying that I don't have any disclosures about this presentation, and that I hope that at the end of this presentation, you're going to be able to identify the basic and systematic steps to perform a successful and safe total laparoscopic hysterectomy. And let's start with some general information, because as you said, Erkut, there are a lot of good surgeons already doing minimally invasive surgery and doing total laparoscopic hysterectomy. And we all know that vaginal and laparoscopic hysterectomies are safe and cost effective because patients bleed less, they stay short at the hospital, they go back faster to their normal activities, and they have fewer surgical site infections. And that we should use the abdominal approach only for benign hysterectomies in selected cases, depending on the ratio of risk benefits and the discussion with the patients. But unfortunately, we're not there yet. Although minimal access surgery is growing, is not yet the gold standard of care. We're still so far away, like we are today, far away. Minimally invasive surgeries is still far away to be the preferred route for the hysterectomy. And not only for the low or middle income countries like ours, like my country, that unfortunately more than 70% of hysterectomies are still done through an open route. This is also true for the rich countries, including Australia, France, Portugal, the United Kingdom, where the hysterectomy, the laparoscopic hysterectomy rate is between 30 and 45%. And also for the really rich countries like Denmark or Sweden, the rates are between 15 and 30%. So we have a lot of things to do to change this paradigm and let patients access to real minimally invasive surgery and avoid open hysterectomies for their benign cases. But why laparoscopy is not the gold standard yet? Probably because we don't have good exposure and training during surgery and after our residency programs, and because there are a lot of provider barriers, including insufficient experience, lack of equipment, inadequate support from the colleagues, and low reimbursement rates. Just to talk about my personal experience, when I came back from training around 20 years ago, I was sure that I was going to have so many cases in my practice that I was not going to have enough time to do them. And really, I realized in a short period of time that that was not the real case. And I was building the practice by myself because my colleagues were not ready to let patients go to get surgery from somebody else. So the only way to have faster growth for the total laparoscopic hysterectomy is to perform safely and in an easy way the systematic steps for a successful total laparoscopic hysterectomy. So let's start with the first one. And the first one is the preparation and positioning of a patient. Our patients arrive to the hospital the same day. They already read and completed a really long informed consent, and they get general information not only about the surgery, but also about the hysterectomy. They need only 8 hours of fasting. They don't get any bowel prep or special diet before the surgery. They always get cefazolin 2 grams IV 1 hour before surgery. And this is very important. If patients are not sure about the surgery, if they have doubts about what they're going to get, if they don't know what is going to happen about the surgery, what are going to be the consequences, patients, no matter if they're already at the OR, they will go back to the office and we're going to just answer their questions. Patients need to know what they're facing before surgery. The patient is placed and positioned before going general. anesthesia. They don't go to general anesthesia and then patients, because if you do that, patients can have pressure sites and points and pain after surgery. They're placing dorsal lithotomy with the arms tucked to the sides, avoiding extreme flexion of the wrist and pressure points. And we always use shoulder pads to prevent pressure, but also to prevent the sliding during the Trendelenburg at the surgery. We take care about ergonomics, always keep the table in a low position. We have a monitor directly facing the surgeon, the first surgeon and the second surgeon. And it's really important that the complete team, including surgeons, anesthesiologists, and nurses, need to be familiar not only with the equipment, but also with the technique we're going to be performing. We always use the WHO surgical safety checklist, but we also added a specific MIS checklist that asks about instruments, equipment, the lasers, the camera, the pneumo insufflator, the intra-abdominal pressure. And we always set the electrosurgical unit the way we want it to be. This is not a responsibility of the resident, of the nurse, of the anesthesiologist. This is our responsibility, and we need to do it ourselves to be sure things are done the right way. We routinely inspect all the equipment for malfunctions or servicing needs. And the second step is the Foley and the insertion of the uterine manipulator. We use a 20G Foley. Sometimes people ask if that's not like a really big Foley, but 20G allows you always to be sure the bladder is going to be empty, and also if you have a complication including a bladder injury, you already have a big Foley inside to take care of the post-op complication. We are using a Vickers-like uterine manipulator and elevator, but of course you can use any other kind. We like this one because not only we're used to it, but I think it is really good. Basically for the big uterus, it is a good manipulator. Always use the appropriate size vaginal cup to delineate the vaginal fornices. Remember that if you use a really small ring, you're not going to be able to see the bladder. But when you use a big one, you're going to increase the risk of ureteral injuries. So you need to use the size that fits the best the vagina and the vaginal fornices. We always use lubricant to simplify the manipulator placing. And in some patients, we use an episiotomy, not only to place the manipulator, but also to be able to get the uterus out of the abdominal cavity. The third step is the abdominal entry and the trocar placement. Remember that any laparoscopic entry technique is as safe as the others, and you should be using the one you know the best. My group uses the direct entry with a 10 or 11 millimeters main umbilical port, taking care of the fascia and the entry vectors. As you can see in the video, we only use one umbilical clamp, then go 90 degrees and then move to 45 degrees. And when the umbilical port is ready, we confirm that we are intraperitoneal and start the insufflation. We start the insufflation at 15 millimeters of mercury of intra-abdominal pressure, but when the accessory ports are placed, we always go under 12 millimeters of mercury. We never use more than 20 millimeters of mercury. There's a lot of published data saying that you don't see better, you don't have an easier case if you go over 12 millimeters of mercury, and you're going to have much more complications, including cardiovascular complications. Before placing the accessory ports, we check the access point to be sure we didn't have any problem in the entry. We confirm the associated pelvic and non-pelvic findings. Then we ask for the Trendelenburg, and we are not using more than 30 degrees. Remember that a steam Trendelenburg more than 30 degrees is going to push higher the cardiovascular complications and some other complications, including the central nervous system and the retinal complications. We check the mobility of the uterus, rule out adhesions, identify the vaginal cup not only in the anterior but also in the posterior aspect, and recognize the final findings to make the final surgical decisions, including changing the routes. Sometimes you are right here and you decide that, okay, this is not a good case for laparoscopy, or I am not really well trained to do this complex case and I should move to another route. You can see in this patient the vaginal ring right here in the posterior aspect of the uterus. The ports, not only the umbilical, but the accessory ports, are placed according to the uterine volume and the associated pathology. Sometimes we move from the umbilicus to 2 or 4 centimeters below the umbilicus. And we always use 3 5 millimeters accessory ports, avoiding the deep and superficial abdominal wall vessels. Always insert the accessory ports under direct vision. Right now, there is no way to have accessory port complication if you insert it under direct vision. The lower quadrant tracheids are placed under the 2x2 law, 2 centimeters above and 2 centimeters medial to the anterior superior ischial spine. And the third accessory port is placed in the Jain port. This distribution is going to facilitate the suturing and also help to maintain an ergonomic position in the vertical zone. The fourth step is the superior pedicle, and we are doing systematic bilateral salpingectomy during TLH, and we are trying to avoid bilateral salpingo-oophorectomy in patients under 55. Then the mesosalpinx is coagulated and transected. In this case, we're using a harmonic scalpel. We use a lot of harmonic scalpel and ultrasonic technology, but you can use ligashore, any other kind of energy, or only bipolar and scissors, depending on your practice and how you like it better, how you feel better doing it. When you're coagulating, cutting the mesosalpinx, pay special attention to the parametrial veins that run between the ovary and the round ligament. Then coagulate and cut the arterioovarian ligament, the round ligament, and then wide open the broad ligament by traction and contraction. Then we move to the next step to mobilize the bladder. And one of the main things about the bladder mobilization is that you have to find the correct plane. And you can get that by firmly pushing up the uterine manipulator and finding the place where the peritoneum separates easily from the isthmus and the cervix. Stay always at the areolar tissue, and when you find fat, just get away from it. Remember that the fat belongs to the bladder, and when you find fat, you're getting too close to the bladder, you're getting too close to have a complication, and that's the moment you should just get away from it. Identify the vesico-uterine peritoneal fold and continue the dissection anteriorly. Identify the endofascia, the endopelvic fascia, mobilize and push the bladder off the lower uterine segment. And again, in patients with prior surgeries, including C-sections, try to stay relatively high on the uterus to avoid bladder lesions. Again, when you find the fat, you should just move away from it because you're getting too close to the bladder. The next step is securing the uterine vessels, and the important way is to skeletonize the uterine pedicle. Remember that the uterine artery runs between the anterior superficial vein and the deep posterior vein. When you push up the uterine manipulator, you're gonna move the uterine vessels away from the ureter, and this is really important because you always have to be over the vaginal cup. Never get under the vaginal cup because you're gonna get in trouble with the ureter when you do that. We always, no matter if we're using any other kind of energy, including the ligature or the harmonic scalpel, we always coagulate the pedicle at 35 watts with bipolar forceps, and then transect the uterine pedicle. And when you do that, the pedicle is going to fall out laterally, providing a nice and easy avascular access to the vaginal cup. So when you do that, as you can see here, you're going to be able to see the vaginal ring and just cut it in a avascular manner. The next step is the separation of the uterus from the cervix and from the vaginal apex. And you do that by identifying the vaginal fornices while pushing up the uterine manipulator. You can see or palpate the vaginal ring, the vaginal cup, and then we use monopolar pure cut, 50 watts, in a circumferential way around the cup. And again, never get under the cup. You can see here the cup anteriorly or posteriorly, and the ureter is going to be here, probably between 2.5 and 5 centimeters from it. The next step is the uterine removal, and you can do that by pulling the uterus into the vagina in the cases where the uterus fits the vagina. But when the uterus is too large, you can morcellate it through the vagina with a 10-blade scalpel and triple hooks for retraction. Or if you have a really big uterus or limited vaginal access, or you don't feel comfortable about a vaginal morcellator, you can use mechanic electric morcellator. And sometimes you can use an episiotomy to do this because you want a wider vagina before it explodes during the pushing of the uterus. You can now keep the uterus into the vaginal canal to maintain the pneumoperitoneum during the suturing, but as we do, you can also use the sponges inside a glove or just into the vagina to avoid losing the pneumoperitoneum during the vaginal cuff suturing. The next step is the closure of the vaginal cuff, and we always use 2.0 PDS, 22 centimeters. We are not using barb suture because there are already published data locally and internationally, one from my group, that demonstrated that it takes the same amount of time closing the vagina with PDS or Vicryl than closing it with barb suture. And as we are a training center with residents and fellows that want to learn how to suture laparoscopically, they need to get trained. And there is no better way to learn how to do a laparoscopic suture than closing a cuff. So I led fellows and residents to train with vaginal cuffs and not doing it with a barb suture because they're not going to be able to learn how to do it. And the other reason is because of the cost. For us, if we spend more money in some things as sutures, that money is going to get out of the doctor's payment, and we need to defend about that. We always start the closure at the right angle of the vaginal cuff, making sure to include the vaginal mucosa in the first layer. And the second layer includes the posterior peritoneum and the endopelvic fascia anteriorly, and we tie the knot at the end of the second layer, again in the right angle of the vaginal cuff. And this is the final result. And then the last step is the final evaluation of the abdominal peritoneal cavity, the drainage of the pneumoperitoneum on the port side closure. We complete the assessment of the hemostasis and peritoneal cavity. We leave 30 cc's of simple bupivacaine 0.125% in the abdominal cavity for acute post-surgical pain. We used to drain the pneumoperitoneum with positive pressure, but as you all know, because of the pandemics and the COVID, we're not doing that anymore. We're just draining the pneumoperitoneum through a closed system and a filter. We put local anesthetic into the incision sites to reduce postoperative acute pain, and then we close the skin with 3-O-proline in one single knot. And this is the immediate post-surgical result, and this is how it looks 6 weeks after surgery. And we remove the Foley immediately after surgery before patients leave the room when they're still under general anesthesia. They go to a recovery room for 3 or 4 hours, and then they are moved to a fast-track recovery room. They don't go to a hospital room. They stay in a special area at the OR. Patients really fast start clear liquid diet. We encourage early mobilization. We try for them to avoid nausea and vomiting. We actively manage acute pain, and the most of patients are released from the hospital between 6 to 8 hours after surgery. They go with paracetamol 1 gram 4 times a day for 5 days, NSAIDs 2 times a day, suppositories of metronidazole 2 times a day for 5 days, and a sick leave for 10 to 14 days. And doing that, this is our results from our cohort of the last 13 years. We've done a little more than 3,500 patients, and this is going to be published in the next couple of weeks. Our surgical time is in around 95 minutes. The intrasurgical bleeding around 100 cc's. We have uterus from 57 grams to 1,600 grams. Patients stay at the hospital around 9 hours after their hysterectomies, and the sick leave, as he said, is between 13 and 16 days. And this is our complications rates. We have around 3.48% of major and minor complications, and the conversion to laparotomy is around 0.23%. And this is the way we have changed the route of hysterectomy in our hospital in the last 13 years. We started doing only 20% of the hysterectomies by laparoscopy back in 2007, and last year we moved to have 93% of the hysterectomies by laparoscopy in our center. So when you decide to do this in a way you can do it the same way every single time, you're going to be able to move to be the minimally access surgery, the gold standard route for benign hysterectomies. So in conclusion, never celebrate too early. When you start doing hysterectomies, you think you can do everything, and you have to be slowly and not celebrate before you are really ready to do that. Always be creative, because you're going to have a lot of problems about starting minimally invasive surgery service in your hospital. So you need to be creative about how to do that. And always work with a team. You have to build a team and work with a team, because if you don't do that, you won't be able to make big numbers and low complications rates. And as I'm not there, I'm gonna leave you with Falcao in Istanbul, and this is my team. This is my group, the people I work with every single day, and I want to thank you them, because while I'm presenting to you, they're working all the time to let me do these things. So I am going to be ready to take some questions. And again, I want to thank all of you for joining us, and Erkut for your kind invitation. Thank you very much.
Thank you very much, JD. It's a really useful talk for us because there are some young residents in the room and they want to learn more about total laparoscopic hysterectomy.